And we move to our second case, and if the title hasn't been changed, it's Dr. Patrick Mark on renovascular hypertension, to stent or not to stent. Paddy.
Thank you very much. Thank you, Anna. I don't think you've ever called me Patrick before. It's usually Paddy, but thank you very much for giving me the opportunity, and thank you to all the editorial board for coming. It's a real pleasure to present this case. So we're moving from an extraordinarily rare case and a diagnostic challenge to something which is perhaps something we all see much more commonly, and there's lots more evidence out there, but still causes both, more a management problem than a diagnostic problem. So, renovascular hypertension, to stent or not to stent, the flavour of the case is in the title. Now, I'm a nephrologist rather than an endocrinologist or a pure hypertensionologist, so there'll be less renin, no aldosterone measured at all. So, I'll present a 69-year-old female who I saw at one of our, district nephrology clinics, which we operate from Glasgow, but we go out and see these patients. And at the point of referral, she had marked hypertension. This was the clinic letter from the GP, mentioned a blood pressure of 191 over 100 systolic blood pressure at the GP surgery. Because she herself was actually referred from an island that was further away off the west coast of Scotland, she'd already had ambulatory blood pressure monitoring, which was not dramatically different. So I think we were reasonably convinced that there was not a white coat component here. This was genuine hypertension, as much as we were happy with that. We brought her along to the clinic. We took the history. She was a smoker. She was phenotypically normal. And we measured her renal function, found a creatinine of 241 micromoles per litre. So clearly there was significant renal impairment, and bland urinalysis on dipstick. Clearly on lots of antihypertensive therapy. We questioned her about compliance, and at the best of our knowledge, she agreed with compliance. So that's always an issue. But she's on a fairly high dose of a long-acting calcium channel blocker. She's on candesartan at a high dose, bisoprolol, and benflumethiazide, which you can argue about in the presence of renal dysfunction whether that's the best drug. And she also is on statin therapy and thyroxine. So in our outpatient clinic, we went on to perform some quick tests. We arranged a renal ultrasound that day, and her right kidney was 11 centimetres in bipolar diameter with fairly good... So, of course. Early comment, great.
Yeah, on the history, I think that you have a smoker who has impaired renal function and no proteinuria. And I think that this should evoke suspicions, absolutely. And I thought you should comment on it.
Well, absolutely. We had this already. We happened to have access to one test that day, and it was ultrasound was the access to test. That wouldn't have been the test to seal the diagnosis. But I agree. To me, I think the diagnosis is probably clear that this is atherosclerotic renal artery disease already. I don't think there's any debate for this. If there'd been proteinuria, clearly then we'd been opening up to all kinds of glomerulonephritides, and particularly if there was also red blood cells on dipstick, we would be very worried about not rapidly progressive glomerulonephritis. Another question?
Was there an abdominal bruit, and would you like to comment on the usefulness of
there was there was not an abdominal. I remember examining this lady, and there was not an abdominal bruit. I did listen for one on the basis that I wondered about this. I cannot remember the latest literature on abdominal bruits. The other place was I listened for femoral bruits and didn't hear one there, which surprised me, because I think if you start looking for these things, you'll find a bruit in one vascular territory. I suspect I was probably listening in the wrong place, because carotid bruits but as far as I remember, she did not have an abdominal bruit and she didn't have a femoral bruit. I can't remember if there's a carotid bruit, but I think that would have been a reasonable test. If one had access to no other imaging, one could have sealed the diagnosis with that. We had some imaging.
Do you see? You mentioned already renal artery stenosis, so I can ask whether you see atherosclerotic renal artery stenosis in the absence of smoking or diabetes or other cause of severe disseminated atherosclerosis.
I would like to say no, but I've had somebody refer to me very recently at a young age with atherosclerotic renal artery disease. So I wondered about FMD, and I wondered about this, because I would say no, in general, but I just had a case referred to me where I was very surprised, and I do not understand it, and I think they probably need a bit more lipid workup, because it was so surprising to see somebody age 40, non-smoker, referred with atherosclerotic renal artery disease and genuine atherosclerotic disease when a panel of radiologists looked at the imaging. So yeah, I agree. This, however, is not that exciting in terms of we have all the risk factors. We're in the west of Scotland, we're heavy smoker, hypertension. Right kidney looks normal-ish, maybe 11 centimetres, maybe a little small. And the corticomedullary differentiation is maybe a little weak, but it's definitely, I'd buy that for pretty normal. The left kidney, if anyone can see the left kidney, well, but it's in there, and I think one can just about make out what the cortex might be, 6 centimetres. So we now have, for those of you who are non-experts, we have asymmetric kidneys, renal dysfunction, and difficult hypertension with bland urinalysis. The diagnosis is almost certainly, well, it is atherosclerotic renal artery stenosis. So it's a clinical diagnosis. So we need to confirm the presence of atherosclerosis and renal artery disease. So I've given you some options. I just wanted to open the discussion a little bit further. And there are other things one could do that aren't on that list. But I think as many of us are happy enough that that's a diagnosis, what would people prefer to do? Would they like to optimize the blood pressure medically? Should we go and perform some imaging? And if so, what imaging? Or go straight to an invasive procedure? Or just take no other action on the basis that this person's already on 4 antihypertensive drugs, and really we should be looking harder at their lipids and their smoking because we're clearly treating them fairly thoroughly. Does anyone have any comments on what imaging they would like to go on and perform?
I would do either CT or MR.
Well, would you do an MR with a creatinine of 240? Yeah. So prior to 2007, we would have leapt straight to MR angiography in all of these cases, and we sent them all to my colleague Giles Roditi at Glasgow Royal Infirmary. After the initial case report and then our own experience of a lot of nephrogenic systemic fibrosis, we've discontinued doing MR angiography, and we've not seen a case of nephrogenic systemic fibrosis since 2008. So, and we had a case of 22 cases of nephrogenic systemic fibrosis. So I wouldn't be keen to, although from a diagnosis point of view, I think it's probably the best test. CT renal angiography is what we tend to favour in this instance here. I think jumping straight to invasive tests is maybe a little too hasty, and there are risks to that as well. So we initially sat tight. I confess I sent her away, said I'll have a think about it because I knew the clinical diagnosis. But this is just a plot of her creatinine. This is prior to referral, and we're already seeing this pattern from the GP's blood test. It's a very labile renal function with creatinine going up as far as 270, back down. I don't know if this is in response to hydration status or maybe on and off a non-steroidal anti-inflammatory drug or changing dose in candesartan. I'm not quite sure, but creatinine up, back down, back up. So these flares, maybe an increasing dose of candesartan. But when I saw this patient, creatinine had been 241 at the point of referral. Then I repeated it and it fell to 140, and I thought, oh, that's great. But then the next clinic visit, we had it back over 200. So we went on to perform CT angiography. And the CT angiogram showed a tight calcific osteal stenosis of the right renal artery, and heavy aortic calcification. Just show this is where the left kidney might be. This is the right kidney, which is fairly good cortex, looks fairly normal. The contrast is still sitting in the aorta at the minute, and the contrast then arrives, and you can see there's really tight stenosis there. This is a kidney that's just about to occlude, and you can see no contrast going to the left side at all. So this is a chronically occluded left renal artery. So based on the reduced renal function, rather than performing angiography with iodine contrast, we performed CT renal angiogram, and Professor Moss performed this. Unfortunately, he's on holiday this week, but you can see there's a stenosis there. It's less easy to see these, the CT renal angiograms, than the conventional angiograms. And this is a guide wire going across it, and there's a stent being deployed in the renal artery. What happened next? And this perhaps surprised me, and maybe it doesn't surprise me, but delighted to see this is GFR. The eGFR, which at the time of stenting was down at 18, rose fairly promptly up to 55. And there is a blip later on here. This is very recently in April. But we've got prompt and sustained improvement in kidney function over the following year. And that is in the face of also relatively well-controlled blood pressure. Not perfect, but given that here we were on 4 agents and blood pressure dipped around the time procedure and then rose, and for one reason and another, she ended up on 2 agents. So when last seen, blood pressure was 148/88. Given that every vascular bed is also partially occluded, one could debate the actual target blood pressures one should aim for here. One could also debate the agents that we've ended up on, bisoprolol and nifedipine, and creatinine 122, given the GFR that's dipped a little. So she's had a successful overall result from renal artery angioplasty and stenting, better blood pressure control on less agents, and renal function is back to a much improved level. But I caution you here, we have this dip in renal function here, and I wondered if anyone would want to perform any further investigation or simply observe, given that we are now about 10 months, the dip started to occur about 10 months out after renal artery stenting. Anyone concerned? Professor Dominiczak?
So Paddy, this is a good time to re-stenose and block the stent. So would you want to re-image and be ready to perhaps push the balloon across?
That is what we would like to do. The patient is extremely reluctant to go there, and with the previous history of the smoking and the several drugs, that's her choice. We would like to re-image. We've had some debate with our radiologist because clearly the stent, we may have more difficulty in imaging the stenosis, and whether just performing straight to angiogram might be better. Another comment here?
I think definitely you need to ultrasound imaging and to look at the changes in the kidney.
Yep. So you perform Doppler ultrasound looking at the renal resistance?
Doppler, I think the imaging the size of the kidney,
yeah, no,
because that will tell us whether it's reversible or not irreversible. Of the
no, absolutely. I think that's reasonable actually. Yeah, to say if the kidney's got smaller, if the cortomedullary differentiation is less good, or there's every chance that we say this might become less and less treatable with time. Absolutely, as the atherosclerosis goes on.
Have you succeeded in stopping her from smoking?
We've tried very, very hard. We have really no. The answer is no. The answer is no. We have been. I don't know what you can do sometimes, but it can't just be a West of Scotland phenomenon when you have somebody who's presented with so much evidence that they're doing themselves harm. But no, we have not. And it makes you also wonder about throwing all these treatments and exposing to risk as well, because renal artery stenting is not without risk. Is how much risk is somebody going to control themselves? Yeah, absolutely. Yep.
Perhaps a challenging question, but was it really a good candidate to stent? And was the kidney was what the nephrologists call ischemic nephropathy? What was the state of?
Well, I mean, was it a good
it's a challenging
question. They've got to keep the radiologists out. They've got to keep their hand in. But seriously, I mean, we had a good result. We've stented plenty over the years, and I've revised the evidence very quickly. We've stented a lot with much poorer results where we've seen no improvement in no renal function, blood pressure getting no better, and there's some very large randomized controlled trials to prove that. So we would argue if ever there was a case where there was some benefit to be had, this was it. Maybe the other risk factors could have been better addressed, but one does what one can. Yeah. But I think you're right. I do take your point that there was definitely established damage there. The renal function was poor and the kidney was small in size, and there was the patient-related factors. Absolutely. Yeah.
as you just said, the results of the major trials in atherosclerotic renal artery stenosis have shown no benefit with intervention over medical therapy with coral and astral and that kind of stuff. So that raises the question of actually if you went back a little bit further, we know what happened in this case and we need to learn from that, but if you went back a little bit further, did you really consider whether you should image her at all? Because medical therapy is apparently what the guidelines are going to be recommending.
Absolutely. Well, shall we maybe, I would go on to just a couple of slides on these just for the people who are not familiar with the data on astral and coral. So I think if one starts back to pre-astral, so I recruited for astral. My colleague John Moss was one of the lead authors in astral, and it goes back to that. If there's a lesion, go and fix it, and you're bound to do good. And in astral, benefit was not shown. Coral, published just last year in the New England, also showed roughly the same thing in a North American study. Would this patient have come through? I suspect over the 4-year follow-up of astral, or I think 5 years of coral, this patient might have ended up with the same result as everyone else. Over 1 year, there was a lot of signal of benefit, and that's the difficulty. But so astral was over 800 patients, coral was over 900 patients randomized to either renal artery, angioplasty and stenting, or best conventional medical therapy. And looking at the various combined endpoints for the two studies, there was no benefit on either blood pressure, renal function, or death or cardiovascular events. And I'm quoting the data from astral because I'm more familiar with these, because I've looked after some of the patients who've had the adverse events in astral, and these were significant adverse events, often related to cholesterol embolization, which seems to go from being a local renal problem to a sort of systemic disease, and really were leading to amputations of toes and limbs. And with the trials, we've seen renal artery dissection. So we are not enthusiastic, although we have experience with renal artery intervention, we're not enthusiastic, and it comes back to whether we would have offered this. And remember, we offered this in the post-astral but pre-coral era, so maybe it was the right thing, maybe it was the wrong thing. So who should actually get renal revascularization? I think there's so many case series of flash recurrent pulmonary edema, it's difficult to argue against this, although there is still a school of thought saying that maybe one should still perform that trial. Refractory hypertension, I think if you look at the data from astral, you say actually there's no evidence for performing renal artery intervention for refractory hypertension when you look at the blood pressures that went into astral. But I'd be interested in the comments of our experts. Again, rapid decline in renal function, we sort of did it here. And again, I don't think it was the right idea. So I put question marks after these. It's always worth thinking about renal revascularization, because otherwise these enormous trials, or these big trials for the renal community, have thrown the baby out with the bathwater, and there may be no patients who benefit. So who should not be revascularized? Stable renal function, well-controlled blood pressure, slowly declining renal function, kidneys that are knackered. And these are the unknowns. The unknowns are the patients who didn't go into the randomized control trials. The patients where their nephrologist, their cardiologist, their hypertension specialist knew best and didn't put them in trial, or the patient didn't want to go in the trial, didn't like the idea of uncertainty. Renal artery stenosis and heart failure is a group where some people are interested in. And maybe there is a need for some better tests to determine functional renal reserve, to see if any kidneys are salvageable or will respond well to revascularization. And there's various imaging studies or ultrasound or MR studies have been done to look at these, but never in enough patients to answer these questions. So I'll leave it at that and open it back open to any further discussion.
Okay. So I start with the questioning, asking you to show us again the picture of that narrowing.
Go back.
Yes, narrowing and closing renal artery for everybody to see. Yeah.
No, it's better on a CT. Yeah,
this one. So there is a tiny, tiny flow there.
Yeah, it's like a hair almost.
Yes, and it's about to close. So ladies and gentlemen, acute physicians in the audience, what would happen next had nothing had been done?
Yeah.
What would have happened next? Nothing? Well, I've had identical patient. This was my first patient in the blood pressure unit many years ago as a registrar. And we published this paper with Chris Isles. And I'll send you. So what happened to the patient next was that she became anuric, was the same age. Everything was very similar. She had malignant hypertension, just to make it more dramatic. She completely relied on the tiny bit of one closing renal artery. The other is really occluded. And so this is a tightening stenosis to a sole kidney. And next is dialysis, and that's it. So I think it's very, very difficult. It's easy to criticize. Professor Moss not here, so let me be his advocate. I think it's very easy to criticize, but clearly now, 2 years later, this patient still doesn't need renal replacement therapy. So something has been achieved.
And if this patient had become volume deplete, dehydrated, anything to compromise that circulation.
Immediately.
Absolutely.
Yeah.
It's interesting. Professor Isle seems to collect these patients, actually, that seem to develop anuria. And I don't know whether it's something about living in Dumfries or he brings them with them. I don't know. But yeah, we've got a series.
Okay, so we have 2 clinical comments here. Yes.
Adrian Brady, Glasgow Royal Infirmary. Thank you very much, Paddy. We had a lot of patients from our series in Astral. Now, for those of us who don't know how you recruited it, if you thought a patient had a stenosis like this, they never went in the trial. They got angioplasty. And so all the patients with 50 or 60% stenosis that you weren't sure, they sort of got put in the trial. I can't speak for Coral, but I bet you for the Coral centres, which are mostly North American, those patients with really severe stenosis were never included in the studies. And so those trials actually tell us nothing about critical stenosis. And for this individual, I think this shows clear benefit. Paddy, the other thing you might like to comment on is the existence of a raised creatinine. Always tells you that it can't just be single renal artery stenosis with a perfect kidney on the other side.
Oh, absolutely. Because we take kidneys out of live donors who go on to give transplants. A single, one kidney will give you normal kidney function with a normal serum creatinine. So clearly there's bilateral disease here. This kidney, the kidney on the other side is defunct. It is not working.
This is solitary kidney, solitary functioning.
Yeah, absolutely right.
Okay. There was another comment here, and then you. Yeah.
Thank you, Paddy. Jess Dawson, also from Glasgow. I will support you and say that I would certainly have referred that patient for stenting, and if I were to go back in time, even with the trial data, I would still refer that patient for stenting. I think the more interesting question is, what would I do now, now that the renal function has declined? And the question I have to help me make my mind up is, how much of the bounce in EGFR, the improvement and the subsequent change, was due to perioperative stopping of the angiotensin receptor blocker and perhaps restarting? Or was therapy the same the whole way through?
No, therapy was not the same. And I think I can't answer the exact magnitude of each change, but the day post-stenting there was a drop in blood pressure, which may or may not have been picked up in the graphs because she had torrential natriuresis, diuresis, blood pressure dropped, all drugs stopped. Then of course, all drugs stopped in somebody who's got widespread vascular disease, and blood pressure eventually goes back up again. So it was a very labile, evolving situation, and it makes it extremely difficult to reinterpret what happened with the reintroduction of and we didn't reintroduce an angiotensin receptor blocker, which, as there was no other compelling reason to do so, no proteinuria, no heart failure, we didn't do that. But I think that's right. I think reintroducing any antihypertensive drug will probably lead to a relative drop in renal perfusion again in somebody whose kidney is used to 200 over 100 blood pressure. It's very difficult to interpret all this. We don't know what her actual baseline is. It's very wide.
Okay, got it.
Just a comment on the issue about whether the people with the really tight stenoses didn't go into these trials, and therefore we don't really know. Coral, they did a retrospective subgroup analysis, you probably know, and those with a stenosis over 80% didn't show any different outcome than those with a stenosis less than 80%. You probably need 80% for it to be hemodynamically significant.
Yeah, yes. Well, that's the other thing we were discussing last night about whether there'd be merit in fact, perhaps you care to comment, Mark?
For your functional renal reserve, and do you have a proposal of a cutoff where you should do it?
I don't. I mean, I think in Astral, the patients who went in were I can't remember the entry criteria, but it was at the sort of 50 to 70%. It was a less severe stenosis. But we should.
But for you, what in your opinion, what But should be a good cutoff for...
Well, in terms of in terms of imaging...
renal functional reserve measured with a pressure wire, for instance.
Well, we don't pressure wire. We have no experience of pressure wiring. We have some experimental experience of doing MR perfusion renography, which has been published by the Manchester group, which does look quite impressive at predicting response to renal revascularization. We don't have a big enough case series of those. I think it comes back to the ultrasound, actually, though, that if they have a decent-sized cortex and a reasonable-sized kidney, there's a reasonable chance it might be good. If it's not, if it's a 9-centimetre kidney or below, probably unlikely to be any good. There's that, this was an 11-centimetre kidney. What if it would have been a 10-centimetre kidney? I think it's very difficult, and that's where more data are still required.
Okay. Matthew Walters.
Thanks, Paddy. Matthew Walters from Glasgow. I'm going to test Anna's earlier assertion that there are no stupid questions by asking a very facile one related to imaging, if I may. Yeah. If the question in this patient, now that their renal function is deteriorating 9 months after the stent was inserted, if the question is there in-stent restenosis or not, what's the role, or is there a potential role for contrast-free imaging using, for example, time-of-flight magnetic resonance angiography that would obviate any risk of contrast-induced injury to the patient, but may be sufficient to answer the specific question about the presence or absence of in-stent restenosis?
I'm not sure that's a stupid question. That's way over my head. No, seriously, I think the issue with MR angiography, time-of-flight, beautiful, but artifact with the MR imaging related to the actual stent itself is going to make this difficult. I don't have any experience with it. We have often actually just gone back to using Grant Baxter, who's got a lot of long series of large interest in Doppler imaging. So for what it's worth, it may be useful in these isolated cases, because if the Doppler was completely normal, then that might be reassuring. Ultimately, I think we've ended up by default sitting, whistling through our teeth a bit, and then going back and performing a formal angiogram. But I think something in between would be nice.
It's probably more difficult to get to the renal than to carotid that you do.
Yeah.
Matthew is a stroke physician, so I think it's much more difficult to get good picture. I don't know. Once we get 7 Tesla MRI, we'll be able to do it. Right? Okay, any other comments? No? Yes? Jan Stassen?
Why would you do the imaging again in this patient? What would be, suppose you find out that the stent is thrombosed, what would you do?
Well,
is there any therapeutic implication?
Well, I hope it's not thrombosed, because I think the renal function would be considerably worse if it was completely thrombosed. If we find, I think that's an extremely difficult question to answer. If we find there was a significant degree of in-stent restenosis, go back, subject to another procedure, go around the loop again. On the other hand, coming back to Anna's point, dialysis, if it is that close to the stent occluding completely and rendering the patient dialysis dependent, that's such a significant risk to life, quality of life, cost to healthcare, everything. But I think what evidence there is for treating in-stent restenosis in stented kidneys I'm unaware of any. I think it's an extremely good question.
However, the invasive radiologist who is on holiday would say, I would just put a balloon through and it would be fine.
Yes. Yes.
So if we are spending so much money or intend to on this patient, why can't we spend a lot of money on stopping her from smoking, which surely may have contributed to any additional vascular damage that has occurred since the recent intervention and stenting. I mean, there are intensive programs that have quite a high degree of success.
I agree. I can confess, I'm a nephrologist. I deal with people in dialysis who cost £40,000 a year. So I'm not a person to speak about economics. But we are limited by what we can encourage. We can ask the general practitioner what they can do. This person lives in a fairly remote island, so they may not have access to the full gamut of, group therapy, counselling, nicotine replacement therapy, all the adjuvant novel therapies. So it's pretty simple.
Last point.
I'm sorry, just following Ernesto's question. So the question is, how often do you see this kind of patients? If you see very rarely 1 or 2 patients a year, I think that's not a problem. We actually had a very similar case as you had. A rapid renal function decline is a very good indicator for stenting, I think. Not really the severity of stenosis, but rapid declining. It's a very good indicator.
Actually, coming back to earlier discussion, we don't currently look very hard for renal artery stenosis beyond the clinical diagnosis, particularly in the post-astral age, and perhaps even more so in the post-choral age as well, because we don't really pursue renal artery stenting as aggressively as we did in the late 90s and through the 2000s before astral went. So we don't see very much of this. We looked at this because of the labile renal function. And renal artery stenting, I'm sorry Professor Moss isn't here, I don't think we perform maybe more than 5 or 10 a year when we used to have, Adrian will know more than this, we used to have hundreds, with loads, but we don't see that much of this now. So.
But that's not because we don't have lots of atheroma. There is still lots of atheroma. We're just not investigating and doing the procedures.
Absolutely.
Okay, I think on that very positive note, thank you very much, Paddy.